Good evening, sir.
Yeah, you can start.
Yes, sir. So, first of all, I'm thankful to the organizers and to Dr. Chattopadhyay for giving me this opportunity to present this rare case of a truncus arteriosus with an intact ventricular septum. This would be an echocardiographic depiction of a baby which was prenatally diagnosed with having truncus arteriosus with an intact ventricular septum. So basically, Truncus arteriosus itself is a very rare congenital anomaly consisting of only 0.7 to 1.2% of the total congenital anomalies. And within this share, only 4 to 5% of cases are reported with Truncus arteriosus with an intact ventricular septum. Basically, there are two types of classification with Truncus arteriosus: the C classification, that is the Kohler-Edwards classification, and the Van Praag type of classification. So, Truncus arteriosus with an intact ventricular septum falls into the type B classification of the Van Praag and Van Praag classification, which is very rarely reported. And the incidence of this kind of lesion is not known. So, this is the first echocardiogram, which was done of a 24-year-old female patient done at 23 weeks of gestation, which showed two good-sized ventricles. And there was a single great artery which was arising from both the left and the right ventricle. There was no ventricular septal defect. The interventricular septum was intact. This is the 5-chamber view, which showed two good sized ventricles with an intact atrial and intact ventricular septum, and a single great vessel, which is giving rise to both aorta and the pulmonary arteries, that is the truncal valve. So after the child was born, he was followed up with the neonatal echocardiograms. At 3 weeks of age, the child presented with failures of congestive heart failure, hurried breathing, sweating, and mild cyanosis. And there were bounding pulses present. So the first neonatal echocardiogram was an apical 4-chamber view, which had a situs solitus levocardia. There was mild dilatation of the left-sided chambers. Interventricular septum was intact, and there was a common trunk overriding the crest of the interventricular septum, giving rise to both the aorta and the main pulmonary arteries. This was a type 1 kind of truncus because the main pulmonary artery was visible, which further divided into the left and the right-sided pulmonary arteries. The parasternal long axis view again confirmed the findings of the apical 4-chamber view, which showed the common trunk receiving egress from the left and right ventricle, giving rise to the aorta and the main pulmonary artery. These are the pictures, these are not the videos. So this is the right pulmonary artery and this is the left pulmonary artery, which are of good size, 4 and 4.7 millimeters for a neonate. Subcostal swipe confirmed the same findings. A common trunk, which was the truncus, giving rise to the aorta, and the main pulmonary artery, which is arising from the posterolateral surface of the common trunk. The IVs was intact. There was no significant truncal regurgitation or stenosis. So at 6 weeks of age, this neonate underwent a Barbero-Marshall procedure. This is the first echocardiogram after the child was taken for the Barbero-Marshall procedure. It showed there was a significant amount of pulmonary stenosis and pulmonary regurgitation. This is the post-op pulmonary stenosis and the regurgitation, which appeared after the operative phase. So basically, we decided to present this case to the forum because it is a very rare, Truncus itself is a very rare congenital anomaly, and the mixing usually occurs at the level of the VSD. But in this particular case, the mixing occurred itself at the level of the truncus. So it's a very rare phenomena, and hence why we decided to present this case to the forum. This was my echocardiographic depiction of the case.